And we are back. It is time that we shift gears away from matters politics and, a lot of current affairs. I know even when we discuss matters current affairs, sometimes we touch some bit on, the events of health in the country. But we now delve deep into just picking a certain, say, I don't want to call it a condition because it's not a condition, something, in regards to matters health. And we delve deep into understanding the nitty-gritty details about this position. And when I talk about this particular topic, I know it is something that will interest almost everybody, whether you're a woman or a man, because at some point in time, it is your mother who's pregnant, it is your sister, it is your cousin, it is your wife, and also at some point in time, you also as a woman, you are pregnant. So we just get to understand the journey of pregnancy. It is quite difficult because in between, it's not always about, you wake up, you're pregnant, and 9 months down the line, you've been able to give birth. No. It starts from the point of siring, and there's so much that goes into that. There are lots of conditions that crop up in between. If not well managed, that's when you see us losing our babies, maternal, deaths that are quite high. We've seen our very own First Lady championing, for zero, of course, maternal deaths. And we always keep saying, talking about this, and we keep saying that it's really, really important that we are keen to make sure that we protect our babies at the level of birth, and we also protect the mother. And so the protection process starts from way before the 9th month. So let's get into the discussion and get to understand some more in regards to the same. We'll be picking up on some points. So whatever it is that we'll manage to pick on and, exhaustively is what we'll focus on. So we would want you to be part and parcel of the conversation. As always, hashtag Morning Cafe. It is the Coast edition of Morning Cafe at Linda_Lela at TV47KE, and 22047 is the SMS short code. We get to sample some of your comments as we continue. You can as well call us live and ask all the questions that you'd be having. We have an obstetrician and gynecologist on board who's a specialist in matters or in line to journeys of pregnancy, and therefore she'll be taking us through this conversation. Dr. Swabra Swaleh. She's not a new face in this show, probably the second time, and I'm glad to meet you for the very first time, because the other time we were doing this virtually, you were in the coastal, we were here, and I was on the other side of Nairobi. So I'm humbled to meet you.
And you're so beautiful in person.
I think you are incredibly beautiful. You should have had me back then. I was saying, you're Daktari Nimsupu, and she is well articulate. I can tell you for free. So you can be rest assured that you're in for great classes. So Daktari,
yes, please.
Sasa mimi nikwambie karibu ama wewe uniambie karibu?
Karibu Mombasa.
I say Mombasa is beautiful. I am looking at the scenery out there and I'm like, please, why don't they transfer me to Mombasa?
It's home,
Nikaya, but it is home. It is warm, and
yeah.
It is warm, and we're grateful that you guys have been kind to us, and of course the team here also has been really kind to us, and so it's only fair that we get into discussing matters health, the journey of pregnancy. There's so much so, but even before we go deep into that, you probably would be asking yourself, sometimes kuna madaktari wa uongo, and sometimes we bring you specialists, and there's that feeling that maybe you seem genuine or something. Why I think she is genuine is because of this. Give me a moment and let's look at this, and probably let's get her reactions on the same, and you gauge for yourself and tell us whether you think she is legit a doctor or a legit a gyna to be able to address this.
Yeah.
What goes into your mind?
What goes into my mind?
For a moment I got goosebumps as though it is me.
I know. That photo sparks different reactions. And I remember when it came out around that time, it actually evoked the extreme of emotions. But in my head that time, I had a woman who was in front of me dying, and had I not gone into that surgery with my son on the back, we probably would have lost her. So maybe you would ask the question, why was your son on your back?
Yes.
I mean, I'm a woman, and so the same issues that affect other women also affect me. Okay. The nanny had left, we had no other support system. The hospital, and we know with government hospitals how it is, there were no other staff, and we're just the skeleton staff that usually get left during the weekend. And so I have no one to leave my son with. He's crying. Do I leave him down as I do the surgery?
Okay.
So, well, the most comfortable place for him was on my back, and he was quite peaceful. He did not disturb through the whole pregnancy. He was fast asleep. And I saved the woman, and I saved her baby.
Have you followed up to know where she is today?
That child is called Swabra.
Oh, beautiful.
The English version, though, Subira.
Subira, yeah?
Yes.
How old is your son right now?
My son right now is 6 years.
6 years.
Yes.
Has he had a chance to see that photo?
He sees that photo, but I don't think he can quite recognize himself.
Yeah.
But he says, yeah, I operated with mommy on my back. Yeah.
That was beautiful. That was beautiful. I think it's only fair that we keep reminding you that was beautiful.
Thank you.
How dangerous is it to have him inside the operation room?
It was a very dangerous thing to do, both career-wise and also just physically there. Had he nudged, had he moved, had he probably woken up crying, I have a scalpel in my hands, okay? So given the risks, weighing the risks, I think it was still the best thing to have done. At the end of the day, it is not so much the logistics of you want a good result. Did I get a good result? Yes, I got a good result. Okay. There's a living mother, there's a living baby, and that is enough. The rest are details.
Are there points where you were condemned for the same?
A lot, and heavily so. And people came out strongly and said, Dr. Swabra, this is out of order. And I said, yes, I know, I'm aware it was out of order. But then how can you call saving another woman out of order? Okay. I was not out of order.
Would you do that again?
Maybe not. I'm hoping that we have a health system that works, that is fully staffed, that has the facilities so that we do not have to go through it. Yes.
Now I understand. You know, during my research, slowly by slowly, I was like, wow, this is beautiful. I hope you agree with me that she is the best person to handle this subject of the day so far.
Thank you.
The journey of pregnancy.
The journey of pregnancy. Right. I usually say, and maybe I'll start off by saying that pregnancy is not a disease. Pregnancy is a condition and it's a beautiful journey. And when we move from looking at it as a condition, as a disease, then we lose it, okay? Our role as midwives, nurses, obstetricians is just to support this woman from the time she even thinks of conceiving all the way up to when she delivers a baby. Usually we call it 12 weeks after delivery, actually. That's when I hand over the reins and say, fine, now I'm done with you. So it's a journey to walk with her. It's not a disease to take care of. All right, so here we are, and we're talking about the journey of pregnancy. I don't know at what point we should start. You said it starts at the point of, conceiving and, going all the way down, even before probably conceiving. Then moments that I've been told, if you wish to get to that moment where you conceive to get a baby, sometimes you're advised to even start having, your folic acid as early as that. Preconception counseling.
Yes. So I would want to believe it starts from way before. Yes, and sometimes it's even better after you understand your condition, after you understand, the complications that you could witness. For instance, those people who have, different blood groups, or so to speak. I'm told there are instances where, this process begins way before.
True.
Take us through that.
Okay, so I would like to think that pregnancy starts with preconception counseling, which is where we look at the couple, we look at the man, we look at the woman, and then we tease out all the genetic conditions, okay? In your family, is there a history that should be looked at? Is there sickle cell, for example? Is there diabetes? Is there hypertension? Okay? If you're to go into the Caribbean countries, for example, there are conditions, blood diseases, okay? Thalassemias. These are sort of very important things to look at because they could affect on the health of a baby, okay? Some chromosomal abnormalities. I should ask, in your family, do you have instances where the babies have come out with chromosomal abnormalities? Then after that, we reconcile if we need to do tests before you conceive so that we see, are you compatible? One of the other tests that is quite common usually is a blood group, because we know that compatibility in the blood group, if the woman, for example, is blood group rhesus negative, what that means is you could be A, B, O negative, not positive. That could have implications on the baby. So it's so much to prepare, not necessarily to dissuade you from getting pregnant. So upon looking at that, sorting out, is sort of like cleaning house. So you clean the house, preconception counseling, and then you help them get pregnant. The woman should be on folic acid all along. Good. So she gets pregnant. Then we know that the pregnancy itself is divided into 4 stages. First, second, third trimester, and we've added a 4th one called 4th trimester. So
which is this one?
After delivery.
After delivery.
Yes. So first trimester is the first 3 months, generally speaking. The middle 3 months, second trimester, and then the last 3 months. And in each trimester, the focus is on very specific things, okay? I enter into the details. Let me kill you all with the details. So first trimester, we're very interested in the very first scan. We call it the early obstetric scan. life begins with the heart. I see the heart, I know we started. Your heart stops beating, I know we've ended.
Right.
Yeah? So I would like to see, do we have a beating heart? Because in the absence of it, you could actually be pregnant and not have a beating heart on the baby, and we call that a blighted ovum.
Okay.
And then we have to clean that out so that you start afresh. Is the pregnancy located in the correct position? Is it in the uterus? Is it in the tubes? Is it outside the tubes and the uterus?
Oh, this is ectopic.
Yes.
Okay.
So an ectopic pregnancy is any pregnancy that is situated outside the uterus. Could be the abdomen. We found one on the aorta, the major blood vessels, in the tubes, in the ovary, anywhere. As long as it's out, then we know how to deal with it.
Are there chances of survival for these babies?
Absolutely,
Okay.
yes. So usually some ectopics, the ones found in the tube, forget about it. Those ones we have to take care of, we remove that, yeah? But there are some instances of abdominal pregnancy, which is also an ectopic pregnancy. So depending on how soon you got to find out about it, then it will determine, care is person to person. Maybe let me just put it that, person to person. But yes, we've delivered babies full term who are growing outside of the uterus in the abdomen.
How soon is safe to detect this?
Usually, I would like to do the very first scan. As long as I make contact with the woman, I do my first scan, okay? But also, past 6 weeks, because we know that the human heart is formed between 6 and 8 weeks, yeah?
So this baby grows at, a different
Location.
all through?
Absolutely.
Up to 9 months?
You just need blood supply, and you just need the placenta to form, because remember, it is just the placenta that transmits everything from mother to baby. So as long as I can get all that I need from this woman through this placenta, it doesn't matter where.
3/4 of the cases I've heard of this,
Yeah.
the doctor will always recommend termination.
True. That's why I said, depending on how far along you are when we made contact.
Are there times that you probably have doctors that are a bit lazy, in the sense that they'll just conclude that this goes direction without giving it a chance?
So maybe, let me just be very clear. If it is a tubal, meaning on the fallopian tube, ectopic, there's no way a baby will grow on a tube that small. But if it is an abdominal pregnancy and you found it at so-and-so gestation, meaning the pregnancy is well advanced, the baby is grown. All you can do is prepare for a very safe delivery. But yes, you can take all the way, take the pregnancy all the way to term so that you deliver the baby.
I'm trying to eat is that we cannot be able to have this conversation in this 1 hour and exhaust everything.
Very true.
I think it's only fair that we try and balance these. We first start, just having the key things to understand on a normal pregnancy. This is a normal pregnancy. It's from A to Z. So when we understand that, then we come to some of the complications that we'd have. For instance, what you've mentioned, ectopic pregnancy. We probably would want to understand more about cervix insufficiency.
Very true.
We'd probably want to understand some more about multiple labor, those operations and all that. And maybe people who have pre-existing conditions.
So let's take the normal woman, for instance. So I'll do a scan, and then I'll do the panel of tests that are concerned with pregnancy. So these tests, I usually say, are not so much for the woman, they are for the baby. I'm testing you to rule out other conditions that may be transmitted to the baby, that may affect the baby. And so first trimester, my main concern, the drug of choice usually is folic acid for development of a baby's neural system, development of your blood system, development of so many things. Folic acid is a very cheap drug that does magic. And so then we move on to second trimester, and I call it the honeymoon phase of pregnancy.
Don't rush just yet.
Yes.
Why is folic that important?
The baby's brain system, spinal system is dependent on folic acid. The mother's blood levels, blood system are dependent on folic acid. And then this is a period where everything is forming. The body is deciding, well, the nose goes here, the ears go here. And so folic acid plays a fundamental role in deciding how normal your child comes out.
Can that be substituted with what we eat? Because I would want to assume back then, during the times of our mothers, there was no folic acid.
Valid point. I usually say there's a woman saying Samburu who has no idea what folic acid is. You see, all these things are supplements, and what supplements do is they add on to a normal balanced diet. And so if you convince me that you're having a normal balanced diet, you're eating your greens, your salads, then I have no business forcing you to take folic. But then again, you tell me how many pregnant women eat well in their first trimester.
Maybe zero.
They are vomiting, they have cravings for the wrong things, and they have aversions to the right things. So that's where we come in and top up for them. Supplements. Yes.
All right, there you go. So do not miss out on your folic acids. And even after, at least that's the knowledge that I know. After you've given birth, you continue with the folic acids. All right, now we come to that beautiful stage that you speak about.
The honeymoon phase.
Yes.
Why we call it the honeymoon period is because you're out of the woods, you're no longer vomiting, you're not feeling tired, you're not moody, you're not crampy, and yet the pregnancy is still not heavy on you yet. And so you're in that beautiful cocoon where things are just right, you're glowing and everything. Second trimester, the most important thing will be to give you the drugs that probably were not allowed to be given in the first trimester. One of them is the malaria medication, tetanus injections, and maybe dewormers. Number two, and most important, is a second obstetric scan. So I mentioned the first one, this is now the second one. We call it an anomaly scan. I want to see how normal is that baby that you formed. I'm looking at the brain, at the spine, at the organs, at the heart. Should you have a baby that is perfect? Good. Should you have a baby that probably has an issue? Then we plan ahead. Do we need surgery for the baby? Do we need management for the baby? And sometimes, in very worst case scenarios, we have a baby that is quite severely deformed and may not survive after delivery. And so we make the decision to probably terminate the pregnancy at that point. So this is usually done between week 15 all the way to week 22. Yeah. So out of second trimester, so the remaining second trimester usually is come in, let's listen to the baby, let's see how you're doing. We're checking your weight, you're checking your vitals, your blood pressure, where are you, your blood levels, where are you, and all that. We're teaching you how to eat, and we may start introducing birth preparation classes. Then third trimester, which usually starts from around 28, 29 weeks, we are on the long run here now. We are tying things up. We are doing the last final sprint. So we are preparing you for your birth. We are preparing you financially as well. I'd like to know, where are you delivering? Okay. Do you have a cover? Such things. The nitty-gritties of pregnancy that are not quite medical are also attended to. I would like to know, do you have a support system? Because this is a woman I'm releasing to the world. How well supported are you? Okay. I don't want a woman suffering with depression after. Then we do our last scan. Usually I like to place it around 36 to around 38 weeks. This scan, I usually joke, is for me. It's not even for the woman. I like to know, how am I delivering you? Are you going to push out this baby? Are you going to have a cesarean? Ama tutamkohoa huyu mtoto. I see. Kama anakoholeka. All right.
That's very interesting. Even before we continue, just having conversations with the oldest, my mom and all that, sometimes they say, you know, kijana anakuja labda a little bit like a week, 2 weeks earlier, masijui kama amechelewa, kijana anauma zaidi kushinda jinsi anavyouma, you know, mtoto wa kike, something of nature. Is there any difference in terms of care? You know, once there's the scarring process has been done, it's determined that it's a boy. Is there anything special that goes into either taking care of the girl child or the boy child?
No, the differences are not based on sex, they're based on other obstetric conditions. If you're carrying twins, I usually say double pleasure for you, but double risk for me. A woman who is carrying twins in my office, she jumps, I jump too. A woman who's carrying 3, we had a woman who delivered 4 children in our facility in February. Trust you me, every time she will blink, I will also blink. Are we okay in our blinking? So maybe the extra care comes, are you carrying multiple? Do you have any other condition added onto it? But in terms of sex,
there's nothing.
We're now.
You better know that. I hope my mom is listening to this, because the numerous things she will tell you. Oh, Samvlana kunywa supu inakaa white, kunywa ingine ya black, and I'm like, really? Does it? But it is interesting because, you know, sometimes even before you do the scan, you know, she will just tell you, in Vlana.
And somehow they usually know. I don't know how. Maybe it's instinct. I don't know. They know some things.
They know some things. All right. So is that all I would want to know about a normal pregnancy?
I would very much insist on the 4th trimester, which is very much neglected. I would put it out there, like a woman has delivered and she feels, I've delivered, I have my baby, why am I going back to the hospital? It's important. You're not yet out of the woods. There's some conditions that could crop up, like hypertension, diabetes, that is specific for pregnancy, that can come even after delivery, I would like to know, are you breastfeeding okay? Is this baby fine? if I operated on you, or maybe you had a tear down there during delivery, is it healing well, or are you, coming down with an infection? Okay. Is your mental health okay? Because we have so many women here with postpartum depression and not even realizing that they have postpartum depression. So I would like to follow you. It's sort of like landing a plane. We took off. Can we now properly land this plane? Not just out of nowhere we ended care. Yes.
Are we actively having this happening today?
In our facility, Premier Hospital, yes, we do. I insist on it, and the antenatal card in its completeness has a segment for postnatal care. Yes.
All right, let me call her Dr. Swabra Swaleh. We take a short break, and there's still more to learn about this. It's interesting how the journey of pregnancy is as well interesting, because it is always different. Baby number one, it's different. Baby number two is different. So you learn things on a daily basis. You learn things as you go through this journey. And therefore, it is important that you learn this. I mean, you say that probably I've said before, but such is not the case. So it's important, and I repeat, it is really, really important that you learn some more on this. And therefore, let's take a quick breather, and then we come back and expound some more on the journey of pregnancy. Now we get to the details of some of the conditions that could crop up at this point in time. Welcome back to the broadcast. The conversation this morning on Matters Health, a journey of a pregnancy. We've spoken about, a normal pregnancy, that typical one where you sire and in 9 months, boom, the bundle of joy is out here. But, there are very many women out here who probably go through tough times, during their journey of pregnancy, and therefore we want to look at some of the things that are possible, some of the conditions that would crop up, in this beautiful journey that would probably need medical attention and more keenness as we're handling these mothers. And so we delve deep into 2, 3, 4 of them. I hope time would allow us, alongside Dr. Swabra Swaleh. I say this name, with so much caution, because it can be a tongue twister, and then you'd start condemning me for that reason. And we are glad that she's here. We started by saying that she's done tremendous in her sport, and therefore she is best positioned to have this conversation. We still also have some feedback from you, which we're grateful for. We say asante sana for your feedback, and therefore I think it's fair that we look at this. There's one that I have taken note of from Reggie Gang, who says, "Hello at TV47, I have something to say, but inataka DM hapa ni open sana. Please, can you check DM?" I think even the best DM to hit is that one of Daktari here, and so I'll allow Daktari to probably give us her number briefly, so at least maybe Reggie can slide in there. I can understand that some of these things really can be a bit personal. The journey of, you don't just want to come here and speak about your journey out here, and therefore we'll allow you to do that. Purity Manika Fupi says, God bless her always for the passion in her job. How dangerous is ovarian cyst if not treated? That is also a question, and maybe we'd need to touch on that, because most of the women who go through this would be worried about, whether they would be able to get children, to sire, and all that. So as you answer that briefly, just give Reggie Gang your number. or the number that she can get help from.
Okay, yes. Right. I will just say, get in contact with Premier Hospital. I'm always in Monday to Saturday, 9 a.m. to 5 p.m. But my number is 0719-238-456. Please, I'm a married woman also. I shall mention that on air.
Oh, really? Cameraman, I hope you must hear.
About the ovarian cyst, maybe I'd like to get clarification. Is it an ovarian cyst in the event of pregnancy or before pregnancy? Because how we manage each is maybe quite different, and then also tailored patient to patient. Okay. So not all ovarian cysts are the same. We have hemorrhagic cysts, dermoid cysts, simple cysts. That is a whole topic on its own. Do all ovarian cysts have to equal surgery? Not really. Some we just observe and they go away. Do they prevent you from, getting babies? Not really, unless maybe not to mention, a complication of ovarian cyst will be ovarian torsion, such that this heavy mass that is growing on your ovary could suddenly twist and cut off a blood supply to the ovary, so that now the surgery changes and I may have to go and remove your ovary, leaving you with one. So not all ovarian cysts are to be, managed surgically. So I'd say maybe let her come in so that we can deal with her case, because it's patient to patient.
Okay.
Yes.
Okay. Now we take it a bit, further, we talked about ectopic. Do you suppose we touched on the key things that we need to know?
Yes.
And I mean, is there something that would probably be told to these ladies who are out there that would give them hope that, well, it could be ectopic, but you need not to worry. It's not as dangerous as it appears, because sometimes you're told that, once you undergo, I don't know whether it's an operation or what, or, mini operation, you're not even able to give birth again.
Birth again, no.
Yes, and I can tell you there's stigma around that.
Yeah.
The first time I heard of it, it was about my friend, and everyone was talking about it, and everyone had this feeling that she's not going to give.
But she gave.
She did. Later. I mean, way later, but yeah.
I get you. So, as I said, an ectopic pregnancy is any pregnancy that is not growing inside the uterus. Now, the first trimester scan is very important, because you see, I would rather I catch it on scan with it not presenting. Okay, you would never know you have an ectopic until the day it bursts. Now, when it bursts, now that's where the trouble comes in, because usually it ruptures some blood vessels, and so you're bleeding inside. And so it can range in presentation from the woman who you just saw it as a by the way, to the woman who comes in gasping. We're almost losing her. And so then the presentation then guides us on the management, because not all ectopics have to end up with what? Surgical management. We don't have to go for theater. Some can be managed by medicine, okay? If I catch it, it has not ruptured yet, it is still tiny, I could give you some medication that shrinks that pregnancy and sort of killed it, okay? So that will take care of it. If it has ruptured then, and we go to theater, the surgery of choice is usually laparoscopy. I think we touched on that last week. And we can try and salvage your tube. Sometimes if it is not possible, all we do is just take out the tube. But you see what that means is I've left your ovaries, both of them, and you have one tube. And one tube is more than enough to give you another child.
Okay.
Yeah. Okay. So it does not mean that now, from now on, you're not going to be able to have children, no. Yeah.
All right. Okay. Cervix insufficiency is one also. After posting after having this post going around, there are a couple of people who raised this, and they said, well, in the journey of pregnancy, I'd love to understand more
about
on cervix insufficiency. And sometimes we get to learn about these things when we are in trouble, when it is happening to us, and in most cases we're not able to save our babies. Sometimes we're not even able to save our own selves.
Yeah. I like that you say that. You get to know about it when it is happening, because that is exactly how we make a diagnosis of cervical insufficiency. Sadly, so that a woman will probably tell you, I had the first baby, okay, and then after that, every pregnancy, when it reaches this gestation, it pours. It reaches imamwagika. Actually, wasema mimba ilimwagika. Now, the interesting thing about cervical insufficiency and how we can quickly zero in is the first pregnancy was carried much further in gestation, and then that gestation keeps reducing. So, for example, you go to 32 weeks, and then it poured out, and then 30 weeks, and then 20 weeks. You understand? So it keeps getting, because this door is getting weaker and weaker and weaker with subsequent pregnancy. So maybe to explain, you'll allow me, the cervix is not just a round thing. It's like a tubular structure, kama vile spaghetti, with a hole inside, yeah? So we usually call the inside door that connects to the womb the internal os, and the outside door the external os. Mlango wa ndani, mlango wa nje. Now, this distance between the inside and outside door has a measurement. It's supposed to be 2.5 to 5 centimeters. Should it fall short than 2.5, even I worry that this door is a bit too thin and will give way, because guess what? The baby is seated on the top or other inside door, and so we'll start opening it from the inside door. So usually that's why we do scans. I quickly do a scan and I measure the length of your cervix, and if it's short, then there is a role of placing a stitch. It's sort of like a gunia. You're just putting a rope around it. Okay? It's done in theater. Now that stitch stays there. The body does not take away that string until the day I decide to remove it, which is usually 37 weeks. It is one of those conditions that are so easy to manage. It's a 5-minute procedure, and that stitch saves lives. So cervical insufficiency, yes, can be cured in the sense that I will not give you a good cervix, but with every subsequent pregnancy, I can contain your pregnancy. Yes.
Okay, so the process of containment begins as early as that moment.
Usually we
especially for people who have an idea that, well, maybe they had that experience before.
Very good.
Okay.
So usually usually the stitch is placed between 13 weeks and 14 weeks.
Okay.
Why? Because at that point the pregnancy is starting to become heavy. There's a fluid, the placenta, the baby all now gaining weight, and also at that point we can be sure that this baby that we formed is perfectly normal.
Okay.
Yeah. There's no point putting a stitch on a pregnancy that is going to disturb us with an abnormality later on.
All right. And therefore, I don't know whether I should call this diagnosis or what. The moment it has been established that you have cervical, you said cervical, not cervical.
Yes.
All right, insufficiency. Then every other pregnancy you have to go through this
Definitely,
process.
yes. Or we just say, let's put a stitch for you once and for all. And if you're a woman who say you have cesareans every time, why would I remove a stitch down
Pointless.
there? Exactly.
Okay.
Yeah.
All right. So after you give birth, then the stitch is removed.
Yes.
That's what you said.
Usually the stitch is removed for those who are going to deliver normally before delivery. For those that deliver by cesarean, you can choose to remove it or you can choose to leave it. You will still get pregnant again. That door is not like firmly closed. Yes.
All right.
The sperms can still enter. Okay,
I hope you had that. And now that we're talking about cesarean, that's where multiple of labor falls?
Yeah, like trial of labor after cesarean, yeah?
Okay.
So comes this woman who has had a cesarean section one time and still insists, Doctor, I feel like I can push, and yes, it's true. Usually we have several conditions that have to be met. If the reason for cesarean section was a reason that is not recurring this time, then I have no reason cutting you again. I may give you a chance. We call it vaginal birth after cesarean, VBAC, or trial of labor after cesarean, TOLAC.
What are some of these reasons? There are times where people would just say, I want this.
For the first time your baby came sitting like breech instead of head down, and then now this subsequent pregnancy, the baby is facing down. I mean, you have a chance. But if the reason for the previous pregnancy was, for example, your height or your bones did not quite open up, then most likely that reason is going to recur again. So it's usually a patient-to-patient approach, and we tailor. And even when we give you this trial of labor, the setup should be that I have it's called a double setup. As much as I'm allowing you to go, for delivery normally, I should also prepare just in case things go wrong.
Okay. All right. And then we're at that point where, yes, we finally agree that it's possible for you to go through this. On numerous occasions, there are instances where ladies have been told, you can't go to the fifth. You can't go, especially when you always undergo cesarean.
True.
And so the advice, you just stick to two.
Stick to two. I personally have delivered one child and had 2 cesareans, and I don't think I'm done yet. Maybe I don't. My grandmother had 4 children, had 4 cesareans, and so I've operated on a woman who was on her 7th cesarean. So there's no right or wrong. At the end of the day, how many children did you want to have? And so usually when you get to 3, 4, we start observing you and start frowning, and I'm sorry we use that word, but it just becomes more dangerous every time, because the scar or the cut is placed exactly the same place on the skin and in the uterus. We forget that. We just see the scar on the skin and we just think that is it. Inside the uterus, we cut exactly the same place, and then we repair, and then the same place, and then we repair, and then the same place. So you can imagine if you're on your 4th, your 5th, how dangerous and how weak that repair site gets with time. So usually 3, 4, we start frowning and tell you maybe we now finish this journey.
To cut on that. The healing process after CS, little bit different from for
I
different people.
Say no. It's a major surgery, yes. So of course complications are there, yes. But at the end of the day, with good pain management, with good post-op care, usually they should do the same as a woman who has delivered vaginally. All
right. I know there's more about that we love, and there's some of us who just choose to go that direction because we think, well, yes, we do not want to go through the process of pain.
I usually joke to my patients that whereas a woman delivering normally has her pain in real time, after she's done, a woman who has had cesarean, your pain is waiting for you after. So, and in any case, the pain of raising this child is the same.
It is the same.
You all don't get to sleep. So I'd say there's no right or wrong. And yes, before we used to frown upon it, that you cannot just choose, there has to be a reason. But again, we all have choices, and we should be allowed to make our choices. So yes, sometimes we do grant patient request.
All right. we all say that we're different, and sometimes we have these conditions, pre-existing conditions, and we've seen even in time of COVID-19.
Very true.
There's more care and there's more of an eye that is being put to people or individuals who have pre-existing conditions. And sometimes we overlook this because we say, well, this is a whole different part of the body.
Very true.
This has got nothing to do with my diabetes and all that. Just how important is it to have a keen eye, an extra eye in terms of how we deal with these mothers that have pre-existing conditions?
I say pregnancy is a highlighter of all inadequacies. It touches on literally all the systems in a woman's body. And so from your kidney, from your liver, because this body is working twice as hard, there's another living human being inside of you. And so all the systems will be pushed to their extreme. That said, then it highlights that if there were deficiencies here and there, you had low blood level, it will show itself very clearly. If you had hypertension, it will show itself. If you had diabetes, because the body is being put under excess pressure to produce nutrients for this other child, it will show itself. There are some conditions that we highlight in pregnancy, for example, diabetes, as you said, hypertension, and from the 20th week, we usually go on high alert. I would like to know how are your pressures, and that is the whole point of antenatal anyway, so that I get to track your pressures. I will also mention that before, the biggest cause of maternal mortality used to be bleeding after delivery. Now it's changed. It's hypertension, okay? So that changes the equation entirely, that I should be more vigorous in my assessment. So, for example, if you have hypertension in pregnancy, and we've reached that point where I feel like you cannot do without medicines, we put you on medicines that are quite safe in pregnancy. We try and monitor how well you're tolerating, how well the pregnancy is tolerating the pressure, and most likely these pregnancies usually end up being delivered slightly earlier. Somehow the pressure doesn't give you time to breathe. At some point it will just flare up and you have to make the decision to deliver this baby even though early. Diabetes, its effects could actually be almost the opposite. A baby born of a diabetic mother is a very big baby most of the times. Oh. Yes, most of them end up with a cesarean because you have this baby that is quite large. They are used to all these calories passing through because of insulin issues. And so most of the women then will end up with a cesarean section. If not, we'll also end up with some complications of delivery, what we call shoulder dystocia, etc., etc.
So what one eats is really, really important.
Yes, really I usually say yes, very important.
These conversations of people cleaning their babies with some alcoholic content is a no. It's a no. I'm told, oh, you eat a lot of avocados, you know what to expect. You eat a lot of eggs, you know what it is that you expect. But well, speaking of conditions, maybe those ones could be healthy conditions, but young mothers, teenage mothers, I mean, we've had cases, quite many of them. How different is it when we're handling this young?
Linda, I'm a product of a teenage pregnancy.
Okay, tell us more. Tell us more about that. You know, the society condemns that as though it's like...
Very true. But, well, my mom was 14, so it was not planned, and here I am. So before we used to say that most teenage pregnancies would end up, say, in cesarean, but even before we get to the delivery, there are some conditions where the risk is already added on. For example, you're a teenage mother, you're most likely going to get hypertension. We know that, okay? You're a teenage mother, you're most likely going to end up with postpartum depression because of the support systems and the events surrounding the pregnancy, okay? Now, usually, when it comes to delivery time, you'd like to assess this woman and see, can this pelvis, this 14-year-old who's not done growing, because we stop growing at around 21 years, her pelvis is not developed, how can it push out a child, okay? And so us pushing her to deliver this child may predispose her to other conditions like a fistula and all those things, yeah? So you may want to save her that. But at the same time, you putting her through a CS, you have to think about healing process. This is the same 14-year-old who is probably looking to go back to school, so you've given her a scar, and she's still supposed to have a normal childhood, like other girls if she's to go back to school. So there's so many things to be balanced, and again, care is, you know, tailored person to person. Let's move to the extreme. There is a 40-year-old, 45-year-old who's also having a baby, again, it's like medicine operates on the extreme. The risk factors stand, okay? In that, first of all, this baby that you're carrying may have congenital abnormalities, medical conditions and all that. And even delivery, we're usually not quite sure, are we going normal? Are we going by cesarean? Let me add a spinner to it. This woman who's 45 may have come from a history of having lost. Why is she looking for a baby at 45, 50 years, yeah? So probably it's been an assisted pregnancy. So we call it a precious pregnancy. How many has she lost? How long has she tried? So it's a wholesome consideration. You do not just look at a woman who's pregnant. We call them social factors. Is she married? How old is she? How many has she lost? How long has she looked for this pregnancy? Etc. etc. Yeah.
Wow, wealth of knowledge. Some of these things you actually do not view them, you know, in such angles. And so as we come to a close, just how important are clinic sessions? Because the majority would want to run away from that. And we all know that it's not always that the dad to the baby is around, but for those who are around, how important is it to walk with your wife or your partner through this journey? My
women at Premier Hospital will tell you, every time they come and ask, where's the husband? Why are we carrying this pregnancy alone? Because we're all gearing up to the eventual, we're having a baby as a family. And so the complications or the joys of it should be shared equally. And even delivery, I allow my men to enter the delivery. If you want to cut the cord, please cut the cord to your baby. Like, we allow the setup to include you, okay? Why? Because there are some conditions that may better be understood by two of them. If I'm talking about diabetes and I'm telling you to eat healthy, you're a pregnant woman. Where is your husband? Who will buy the healthy food, for example? Who will take care of you? You've delivered, you've had a cesarean section. Show me, who will take care of you? Who will help you clean the wound at home? Who will help you carry the baby at night? No, we do not go through antenatal as women alone, unless, of course, logistics here and there. That said, antenatal visits, according to World Health Organization, we moved from the 4 focused visits to 8 visits. Why? To allow as much interaction so that I could pick out all these potential complications and deal with them quite early. It's very important.
All right, this one is the last one as we close. Let's talk to the ladies out there who probably could be having HIV and AIDS. It is possible to protect this baby.
Kabisa.
100%.
100%.
So you need to visit these clinics. You need to go for these sessions.
And prevention of mother-to-child transmission starts in pregnancy. Actually starts pre-conception. Remember we talked about preconceptual care. Yeah, I'd like to know, are you on your drugs? How is your viral load? How is your CD4? Then in the pregnancy, I know the things to do and not to do. In the delivery, I know what to do, not to do, as I safely hand over the baby to the pediatrician who now continue with the care.
All right, we can only give you nitty-gritty details, my friends. And I mean, for those of you who are just joining us, worry not. We'll be having this, you know, on our social media platforms, and therefore it is important that you go back to watch the video afresh, just get to understand some of these things that will be helpful, if not for you, your sister, your mother, your friend. Really, really important that we understand the journey of pregnancy. Dr. Before we come to a close, your last words in regards to just understanding the journey of pregnancy and the key things to be keen on.
Very true. I think antenatal care is one of the key pillars to a healthy mother, healthy baby. It is not so much just going to the clinic. We're usually doing something behind the curtain, okay? Come for your antenatal. Come for your checkups after delivery. Do a birth plan with your care manager and just have a safe delivery, okay? And we have these services in Premier Hospital. Please, come all of you. We'll take care of you.
I will send my invoice way later, but then again, you've been very nice to us. Some of this information, by the way, you have to pay for. And because we love you so much, then we bring you specialists who are going to take you through that, you know, they enlighten you. And I think the best way to reward them is to just do what it is that she says. Let me say that in Lotus. So
Mombasa.
Ndio hivyo. Si basi nizungumzie Kiswahili hata basi tunapofunga kwa sababu nikiwa Mombasa at least na mimi ni learn Kiswahili nisitoke hapa bure sio.
Thank you for having me. Asante. Okay, for being a gracious host. Na karibu tena na tena Mombasa.
Nashukuru sana. What I've seen is worth coming back for. And therefore we'll look forward to engage you some other time. Nashukuru sana for, you know, the passion, as many would have said. We have so much feedback on people celebrating you. I guess it is that moment, and it is that photo, my dog so passionate with her work, happy to watch you. You know, you are making my morning. Great one, always full of knowledge. And you know, you are a blessing, or so to speak, as they would say. And therefore, when we bring life, I think that's the best thing. That's why we value our mothers big time. True, sometimes we forget our dads, knowing very well that they have to be part of this process for us to bring life. And therefore, learning some of these things is really, really important. Remember, we are in Pwani. It is that special edition of Morning Cafe. Pwani Studios, Asante Sana for being good to us, and we promise you nothing but the best for the better part of the week. So make sure that you always tune into Morning Cafe, tune into TV47, the home of Untold Story, because it will be an incredible week right here on Morning Cafe. But as for now, I think it's only fair that we say kwaheri sana, and we look forward to more of great Untold Stories and, you know, general programming so much all the way from Nairobi. And of course, you can make sure that you keep it right here, and you will be enlightened some more, and you enjoy the best of TV47. Asante sana to the team that has made this broadcast a success. We have to close it at that, as I look forward to see you again tomorrow. My name is Linda Alela. Shukran sana. It is a pleasure to always have you. This is Morning Cafe. We close it at that. See you again tomorrow. Bye-bye.
Bye.
Thank you.